Well, the short answer is that is a minimally invasive procedure, okay? And that is what, in a way, we were waiting for, having a procedure that allows a patient to heal from the surgery very quickly with a limited number of complications and potential reintervention in a short period. So GATT is, in a way, allows to reactivate the physiological pathway of aqueous reabsorption. In a way, it doesn't create something artificial like with the trabeculectomy or valve implants, where there is a different pathway of aqueous reabsorption through a fistula or through an external drainage. With GATT, the flow or the aqueous flow goes through his anatomical physiological pathway, which it gets somehow reactivated. So the advantages are that this minimally invasive procedure allows to have the patient to heal and recover from the surgery in a couple of weeks or 3 weeks. And whereas with trabeculectomy, it takes much longer time, and with the requirements very often for manipulations and further procedures that may be performed at the slit lamp or in the operating room. So in a way, it's is a procedure that it may take only 8 to 10 minutes to perform. And it does provide a good level of pressure lowering, certainly not as much as with trabeculectomy, but in a way to a level which it could be considered satisfactory in many cases. It could be used in kids. It could be used in infants. Particularly, I'm referring to congenital glaucoma. And in those cases, we saw that surgical procedures like GATT allows to lower the intraocular pressure with minimum side effects and consequences that are oftentimes very undesirable in these young patients, particularly, and allows to buy time and to postpone a potential possible second procedure, surgical procedure, to a later time when the kid has grown and when, of course, there are better chances for a trabeculectomy or for a valve implantation to perform at its best. So it's being a minimal invasive procedure, it doesn't create too many consequences, as I said, such as cataract formation in these young patients, which is again is another issue with conventional surgery. Otherwise, as you said, it has been used with good results in patients with obstructive glaucoma, such as you said, steroid-induced glaucoma, in pseudoexfoliation glaucoma, and again, pigmentary glaucoma, and most of open-angle glaucomas, but particularly secondary to obstruction of the trabecular meshwork. Again, we recently tried to use GATT in patients with obstructive glaucoma due to the formation of peripheral anterior synechiae, such as closed-angle glaucomas, and it works very well again. And the reason is because it allows also to remove and open the synechiae and open the angle together with trabecular meshwork. Closed-angle glaucoma has to be, again, studied more, but it seems to be fine. And we thought at the beginning that it was contraindicated in closed-angle glaucoma, but there are techniques for avoiding difficulties with the procedure and performing GATT also in these patients. There are two different, somehow similar but different approaches. One, you basically remove the trabecular meshwork resistance for 360 degrees, and with viscodilation, you basically create a sort of stretching, if not focalized interruption of the Schlenk canal and trabecular meshwork due to viscodilatation. There are no comparative studies between the two procedures. I would assume that the viscodilation, dilatation of the trabecular meshwork and Schlenk canal probably should work less, achieve a lesser intraocular pressure lowering. The advantage potential is that it could be repeated either by doing a second viscodilation or a GATT, a trabeculotomy ab interno. So in a way, we are comparing two new procedures that need to be further investigated in terms of long-term results and also in terms of comparative results. And so we don't know as yet if being more aggressive with GATT pays an advantage in the long term, or whether being more conservative with viscodilatation or trabecular meshwork may allow to perform sequential procedures as is supposed, and being at the end more in control in the long term with their intraocular pressure. This is something that has to be investigated yet. The only advantage is, the main advantage is economical. GATT has been performed throughout the world in two ways mostly. One is with a suture, which is a kind of homemade suture by cauterizing the tip of a Prolene suture or a nylon suture, or with the catheter. This sharp point suture is ready-made to be used for GATT procedure and is purposely shaped for being introduced inside the Schlenk canal with relatively ease and allowing a good performance and easy learning curve. At the end of the procedure, if the suture is pushed throughout along the Schlenk canal for 360 degrees, then is pulled and with consequent opening of the Schlenk canal and trabecular meshwork, and it normally is visible a certain amount of bleeding coming from the angle for 360 degrees, and that is the indirect sign that the trabecular meshwork and Schlenk canal were open. GATT requires, as with any angle procedure, requires the use of a gonio lens. And to be accustomed to a gonio lens, it takes some time, okay? But again, once you have mastered the use of a gonio lens and being able to work with both hands at the same time, then GATT procedure is relatively easy to acquire, because you have to recognize basically the anatomy and then create an otomy and introduce the suture or the catheter inside the Schlenk canal. Once you master these two things, then all the rest is very simple and easy to do. Whereas, of course, with trabeculectomy and then also with an implant of a valve, there are many more variables that need to be acquired and mastered before you can accomplish a repeatable procedure. So in a way, I believe that it may seem to be more difficult, but at the end is probably much easier than a trabeculectomy. The complications arising from the two procedures, GATT and trabeculectomies, are very different. Okay, with trabeculectomy, the most common problem and the most feared problem is hypotony. And whereas with GATT, the most common problem and complication is bleeding from the angle. And having a certain amount of blood inside the anterior chamber, called hyphema, a few days or the following day following a GATT is absolutely normal. It's just routine. And it has to be like that, because otherwise you may be in doubt whether you actually open the trabecular meshwork or not. So bleeding is not an issue, and it normally goes away in a couple of weeks. 2 or 3 millimeters of hyphema is just routine and normal and usual complication. Whereas hypotony following filtering surgery, whether it's trabeculectomy or valve implantation, puts you in trouble, because you have to deal with the consequences that could be macular edema, choroidal folds, and also endothelial decompensation, all these problems that may create more serious problem for the patients. Pressure spikes following GATT is another potential complication. It is normally due to a remainings of viscoelastic inside the anterior chamber that are left in place at the end of the procedure to tamponate some bleeding. And then that amount of viscoelastic can be evacuated through a paracentesis very easily. So not too many complications, but particularly the management, the postoperative management, is what we call hands-off. So there are no manipulation to do to stimulate filtration, no manipulation to be done to create a bleb, no manipulations that have to be eventually done in case of Seidel, the postoperative period is normally completed within 2 to 3 weeks. Management could be also trusted to not so specialized ophthalmologists in a way, which helps the flow of the clinic a lot, in the sense that because there are less manipulation, less handling to do, you can see more patients in the same amount of time. If you are in a very busy clinic, that is another advantage. Yeah. Couple of hundreds, or probably more than 200 procedure. I started GATT in 2014, 2015, so it's now about 5 years that I've been using GATT. I do use the suture very often. In very complicated cases, I still prefer using the catheter, but I do use the suture in routine cases. I use a catheter in kids. But otherwise, suture is one of the preferred tools for performing GATT because of its ease and because also of this economicity, of course. GATT, as other minimally invasive procedure, do not lower the pressure as much as trabeculectomy, but they do lower the pressure up to at least a 30 to 35 IOP reduction, which in a way is a good target to be achieved. And we've now completed a study with a follow-up of 2 years, and the vast majority of the patients still maintain at least a 30-35% intraocular pressure lowering from baseline. And of course, the same during the same period, patients who underwent trabeculectomy maintain a 40 to 45% intraocular pressure reduction. So the intraocular pressure reduction of trabeculectomy is greater than with GATT. But of course, trabeculectomy is something that it can be done following GATT at any time with absolute the same ease as as a first procedure. Another advantage is the fact that these patients eventually failing after GATT because intraocular pressure rise, they can be treated by trabeculectomy without the use of prostaglandins, without use of other drugs that are known to lower the success rate of trabeculectomy. So in a way, getting the patients out of intraocular pressure lowering drugs is beneficial also for a subsequent procedure should GATT not last as long as expected. Well, probably now is more than 3.5 years. We have several patients still, managing very well with a minimum amount of medication or with no medication at all. And those who are doing the best are certainly the pseudo-exfoliative glaucoma patients and the pigmentary glaucoma patients who are known to be the best candidate for this type of procedure. And those are patients which are very frequent across Europe, particularly in the northern part of Europe, Scandinavia, and in those areas, the number of patients with pseudo-exfoliative glaucoma is very high. The GATT procedure can be combined with cataract surgery with ease, using the same approaches and the same incisions. You can introduce your forceps and your suture to perform GATT at the end of the standard phacoemulsification procedures. We have noticed that combined procedure, phacoemulsification and GATT, does have a small advantage, but probably significant, of about 1.5 millimeters of mercury lowering pressure greater than the standard GATT alone. And so combining the two procedures may have another advantage and potential advantage, which is obviously, very welcome.